Really sorry for that
That's
inconvenient
okay.
moment.
No worries at all.
I think we can start because we will place this record to at our YouTube channel.
Okay, great. So let me, shall I start or wait for others to join?
I think we can start. I will
Okay.
send, yeah, I will send the links to another groups.
Thank you so much for inviting me to speak to you today on contrast enhanced mammography. My name is Kristen Coffey, and I am a breast radiologist at Weill Cornell in New York City. I have nothing to disclose. So we all know that mammography is the only screening tool that has actually demonstrated decreased mortality from breast cancer through multiple randomized controlled trials. But we also know that mammography is a very imperfect screening tool, particularly in women who have dense breasts. And this is related to the masking effect, whereby dense breast tissue that appears white in the mammogram can obscure an underlying cancer. And the challenge with dense breasts is really twofold. So, sensitivity of mammography is not only inversely related to breast density, but breast density also confers an independent risk factor for developing breast cancer. So, women who are more dense have a higher chance of developing breast cancer, and mammography is performs poorest in these women. So I'm going to start off with this very quick case. This was a 32-year-old who presented 1 year postpartum with symptoms in the left breast. I believe it was nipple discharge. Her mammogram was negative, but you can appreciate she's extremely dense breast tissue. Her clinical symptoms were so concerning that she then proceeded to have an MRI, and we can see that MRI shows over 10 centimeters of multicentric high-grade DCIS that was, even in retrospect, completely occult on the mammogram. And so I like to show this case because it's just a very humbling example of the power of vascular-based imaging when compared to mammography. So contrast enhanced mammography has actually been around since 2011. It was approved in the United States for diagnostic use. And the power of contrast enhanced mammography is that it is both a morphology and a vascular based imaging technique. So when we say morphology based, we refer to the low energy image, which is identical to a mammogram, which depicts anatomic changes in the breast, masses, calcifications, tissue distortion. But it's also a vascular-based technique similar to MRI in that we give contrast to detect tumor neovascularity. We are able to acquire both morphologic and vascular information using a dual energy technique that uses X-ray energies both above and below the K edge of iodine, which is the contrast. And in doing so, we are able to generate a high energy image, which is the X-ray beam that has energies above iodine's K edge, and then a low energy image, which is shown here in the middle. Again, totally equivalent to a regular mammogram. And then using both of these high energy and low energy images, a post-processing algorithm can generate a recombined image. It's sort of like a subtraction, but it shows only enhancement. When the patient presents for a CEM study, they first have an IV placed. We inject IV contrast with the breast out of compression to facilitate greatest amount of blood flow. And we inject an iodinated non-ionic low osmolar agent, very similar to contrast CT, at a dose of about 1.5 milliliters per kilogram at a rate of 3 milliliters per second, usually through a power injector. And schematic show we start approximately 2 to 3 minutes after contrast injection, and then we acquire the paired low energy and high energy images for each of the four standard views in no particular order. And you have the option to acquire an additional view. For example, perhaps your protocol includes a spot view of the lumpectomy site. But the overall goal is to finish your imaging within 8 to 10 minutes, after which the contrast has likely washed out. Then there is this post-processing step, which I mentioned, and that is when the high energy and low energy images are recombined to form this recombined enhanced image. Now, the radiation dose, because there are 8 exposures, is slightly higher than a standalone 2D mammogram or a tomosynthesis mammogram. However, earlier this year, there was a paper that actually measured all of the radiation dose per protocol, and they found that actually the CEM exam had a lower radiation dose than the combination 2D and tomosynthesis exam. So this is important because where I practice, our screening and diagnostic mammo protocol is actually the combination protocol. We acquire the 2D as well as the tomo. So CEM is actually a lower radiation dose. Also keeping in mind, radiation dose does depend on breast thickness, density, vendor, and it's still well under the regulatory dose limit, so it's very safe. When we interpret a CEM, we of course interpret both the low energy and the recombined images. So your hanging protocol when you pull up a CE exam should show both of these views. We follow a CEM lexicon that is outlined in the BI-RADS Atlas, which was recently updated in the 6th edition and released last month. This CEM lexicon was developed in 2022 as an amendment to the previous edition and is now incorporated into the 6th edition. The first thing we want to do when we interpret a CEM is report both the breast composition or breast density, similar to a mammogram, as well as the background parenchymal enhancement, similar to an MR. And studies have shown that there's actually a very strong correlation between background parenchymal enhancement between CEM and MRI exams. And studies have also shown that the hormonal and post-treatment effects that we observe at MR are sustained at CEM. So an example, a lactating patient has increased BPE, a patient who had prior breast radiation or is on tamoxifen would have decreased BPE. They've also shown in a few studies that timing of the menstrual cycle is likely not needed with CEM to account for fluctuations in BPE, similar to MR. So the CEM lexicon encourages us to describe findings by categorizing them into 3 buckets, depending on whether the finding is seen on the low energy image, the recombined image, or both. So to walk you through this, first, let's say we have a finding that is seen only on the recombined image. For these findings, meaning they're only enhancement, we're going to describe the finding similar to how we would on MR. We will describe it as either a mass or a non-mass enhancement with similar descriptors as with MR. A new descriptor with the CEM lexicon is this term enhancing asymmetry. This refers to any enhancement that is seen in one view. And this is unique to CEM because we have 4 views, whereas with MR, it's volumetric. So any one view enhancement, we are encouraged to use the word or term enhancing asymmetry instead of mass or non-mass enhancement. Findings that are seen on both the low energy and the recombined images, we're going to use a different lexicon. It's essentially the mammo lexicon. And so we describe the finding based on its low energy appearance, and then we just say whether it's enhancing or not enhancing. So an example would be a spiculated high density mass with rim enhancement, or a focal asymmetry that's partially enhancing. And then the third category of findings are those that are only seen on the low energy images without any associated enhancement. These are the easiest findings to report because you just use the mammographic lexicon. An example would be calcifications without any associated enhancement. This is an example of one of our CEM templates. I'm just including this to show again that we want to describe the breast density, the background parenchymal enhancement, findings on the low energy and recombined images or both. There are a few artifacts that can be specific to CEM that I will run through quickly. So this is an example of a patient who had skin contamination artifact. We can see high density contrast material in both breasts. And the tech very astutely noticed this at the time of imaging. So she wiped the patient's skin before acquiring the post-lumpectomy spot view, and you can see that that artifact resolved. So this is skin contamination artifact, which can occur. This is an example of rim artifact, which results from scatter radiation. This is an example of ripple artifact, which is related to motion. So again, commonly seen in the lower uh, breast on MLO view. And this is an axillary line artifact that results from a compression paddle that is improperly sized on the patient. Clinical indications for CEM are quite broad. CEM has been studied and is performed clinically for both screening as well as a variety of diagnostic indications that include evaluating screening recalls, evaluating symptomatic breasts, and in breast cancer patients, evaluating extent of disease and response to neoadjuvant chemotherapy. For the purposes of this talk, I'm going to focus primarily on screening because we have the most robust data supporting this indication, and in recent years has been reflected in updated guidelines. This table I created in 2023 for a review paper that I wrote, and I am including this just to show you that around 2023, there had only actually been a few studies evaluating CEM in the screening setting. It was originally approved in the diagnostic setting. And so from this table, you can see that the first study was in 2013. It was led by my former colleague, Maxine Jockelson at Memorial. It was a feasibility study just to show that CEM could be performed in women for screening. And then subsequently, there were only a handful of studies that were performed evaluating CEM for screening. Most of these, if not all, were retrospective, single center, and some had very small sample sizes. That said, these results were very encouraging and promising. CEM showed very high diagnostic performance that was superior to mammography and ultrasound, approaching that of MRI. And now this table actually shows the recent screening CEM studies, which only in the last few years there have been a handful that are prospective, large, some randomized clinical control trials. Now we have more robust data supporting the use of CEM in screening. And I would like to just touch on each one of these studies and discuss some of the key findings. This first study, the contrast trial led by Jordana Phillips, this was a prospective enriched reader study. 132 women underwent both CEM and MRI, and they compared CEM to regular mammography to both a full MRI protocol and an abbreviated MRI protocol. And what they found in this reader study was that, as expected, CEM outperformed routine mammography, and that CEM was non-inferior to both of the MRI arms, the abbreviated and the full protocol MR. One criticism of this study, however, is that because most women who undergo MRI screening also have a mammogram, a true comparison should have been CEM compared to MR plus mammo. But nonetheless, it still showed non-inferiority of CEM. And then this year alone in 2025, there were 3 trials. The first published in The Lancet. This was a very large, multi-center, prospective randomized control trial that evaluated over 9,000 women. These are women who have dense breasts, had a negative mammogram, and they were randomized to undergo supplemental screening with either CEM, ultrasound, or abbreviated MR. And what they found was that CEM was equivalent to abbreviated MR in sensitivity and recall rate, that both CEM and abbreviated MR detected 3 times as many invasive cancers as ultrasound, and these were preferentially smaller cancers that were detected. And there was no cancer that was detected on ultrasound that wasn't already seen on either CEM or MR. And you can see the cancer detection rate very high for CEM, 19 per thousand, which was actually a little higher, but not statistically different from abbreviated MR, which was 17 per thousand. Moving along, now there's a trial in November of 2025 led by Wendy Berg. This trial, interestingly, examined 601 women. These are women who met criteria for screening MR, but instead of undergoing screening MR, they underwent CEM and tomosynthesis. And the idea behind this study was to show that CEM could replace MR for women who were high risk that maybe could not have an MR due to resources or access. And what they found was that there was a significantly higher cancer detection rate for CEM, 18 per thousand compared to 8 per thousand with tomosynthesis. No cancer was detected on tomosynthesis that wasn't seen on CEM. And although CEM did have a slightly higher false positive rate. This supports using 2D low energy images with CEM rather than tomosynthesis. And the final study that came out of Memorial again in 2025, this was a prospective study of women who underwent both CEM and screening ultrasound. And they compared CEM with ultrasound to CEM alone, to mammo with ultrasound to mammo alone. And what they found, not surprisingly, CEM outperformed both mammo and mammo plus ultrasound. Again, there was no cancer seen on screening ultrasound that was not already seen on the CEM or mammo exam. And that although CEM had the highest abnormal interpretation rate, it also had the highest PPV of biopsy, meaning suspicious findings on CEM that proceeded to biopsy were significantly more likely to be cancer than those seen on mammo and ultrasound. So very, very promising results to support the use of CEM for screening. But then there's the question of who to screen. So in the US, we follow the guidelines that are set forth by the American College of Radiology and the Society of Breast Imaging. And these guidelines were updated in 2023 for the first time, including CEM in their recommendations. And so overall, or in general, CEM is recommended for supplemental screening in women who are at elevated risk but cannot have an MRI. And that may be that they're not eligible, they're not quite 20%, or they can't have an MRI because of some contraindication or access issues. So these include women that have dense breasts and desire supplemental screening. We already talked about the BRAID trial that was in the Lancet earlier this year, and we will talk about the CMIS trial at the end of our lecture. These trials are validating the use of CEM specifically for women who are average risk but have dense breasts. There was also a study out of Memorial Sloan Kettering that showed that among women with extremely dense breasts who underwent CEM, CEM outperformed regular mammography, detecting an additional 9 cancers per thousand. Then there's the intermediate risk group of women who have a lifetime risk of developing breast cancer between 15 and 20%. Many of these women do not meet criteria for a screening MR, and that may be due to a lower risk family history, a personal history of lobular neoplasia or atypia, or a personal history of breast cancer, perhaps diagnosed at a later age or with non-dense breasts. I would say this population of women has been the study sample for many of these CEM screening studies. The only issue is that it makes the population a little heterogeneous to study. But again, this is a great option for women who are not eligible for MR and really deserve additional screening beyond mammography. A recent trial that's actually ongoing, but preliminary results were published, the TOSIM trial, found that among women with a personal history of breast cancer, CEM outperformed tomosynthesis, detecting an additional 7 cancers per thousand. And then this last category of women, the high-risk women, these are women that are eligible for screening MR. However, we know in clinical practice, some women cannot have an MR, and that may be due to a contraindication that includes claustrophobia, metal implants, gadolinium allergies, or tissue expanders. It may be that MR is not available to them. MR is not always accessible everywhere. And so this was the motivation behind Wendy Berg's study when she looked at CEM in women who were high risk but maybe couldn't access MR. And what an area I'm particularly interested in is women who are high risk, but they're maybe due to a genetic mutation such as BRCA mutations at extremely high risk for interval cancers, whether there's a benefit in performing CEM in these women alternating with MR. Now I'm going to show you a bunch of screening cases. This was a family history, a patient with a family history of breast cancer undergoing a baseline screening CEM. These are her low energy images. You can see she has dense breast tissue, but the mammogram was negative. And on the recombined images, there was a sub-centimeter mass in the lower central breast. This underwent additional tomosynthesis views and ultrasound, which were negative. We didn't have CEM biopsy at this time, so she proceeded to MR, and we see an enhancing correlate in the retroareolar region. This underwent MR-guided biopsy. Clip was in good position, correlating with the original CEM finding, and this was a small invasive ductal carcinoma. This is a patient who had a baseline screening CEM. She had a history of a contralateral left mastectomy for breast cancer. Her low energy images show dense tissue, otherwise negative. On the recombined images, she had an enhancing mass in the outer central right breast. Additional tomo views were negative, but we did identify a correlate on ultrasound at the 8 o'clock axis. This underwent ultrasound-guided biopsy, confirming CLIP corresponded to the original CEM finding, and this was a fibroadenoma. So this is an example of a false positive on CEM, very similar to MR, enhancing masses like fibroadenomas will represent false positives. This was a screening CEM in a patient who had a contralateral right mastectomy, and in the past year, it had an interval breast reduction. And so on the low energy images, we see dense breast tissue, we see some post-reduction changes in the medial left breast. On the recombined images, however, there was a mass in the medial left breast around 9 o'clock. She had additional tomo spot views and an ultrasound. We did find a sonographic correlate at 9 o'clock axis, an irregular hypoechoic mass. So we did an ultrasound guided biopsy. CLIP confirmed it was the same finding. And this was fat necrosis. So concordant, it was along the new reduction scar. Again, another very common false positive that we see on MR, enhancing fat necrosis. This was a patient who had a family history of breast cancer. She was undergoing a screening CEM, and she had had a recent left breast biopsy yielding classic LCIS, which was not excised at the institution I was working at. And so I'm showing you the recombined images first. We can see the biopsy clip in the upper outer left breast and no suspicious enhancement. Just before signing, I looked at the CC view again on the 2D, and I questioned there was an area of distortion, very subtle distortion in the outer left breast. She didn't have a history of surgery, only the stereotactic biopsy. So I called her back, had her do additional imaging, spot tomo views, and there was this area of subtle distortion in the outer left breast. We then did a targeted ultrasound. We found a suspicious irregular hypoechoic mass at 12 o'clock. We did an ultrasound guided biopsy. The clip corresponded to the area of distortion, and this was an invasive lobular cancer. So this is an example of a false negative, the only one I've seen on CEM. And of note, this patient also had an MR it was within 6 months, that was also negative. So I show this case. I think this was just a case of a very subtle ILC. Occasionally, ILC enhances minimally, even on MR. But I also show this case to make the point that the distortion was evident on the 2D image. So we really didn't need to have the tomosynthesis to pick up the distortion in this case. And this is the lumpectomy specimen showing again the distortion with the clip in the seed. Okay, this was a screening CEM for a patient who had a history of left breast cancer. The low energy images show the lumpectomy site in the upper inner quadrant, but otherwise negative. And on the recombined images, there was an enhancing mass lateral and anterior to the lumpectomy site. Additional tomosynthesis views and ultrasound were negative. Again, she went on to have an MR, and we found an enhancing correlate on MR. that then underwent MR-guided biopsy. And you can see it corresponds nicely to the CEM finding. The clip was in good position after biopsy, and this was an ILC recurrence. This was a screening CEM for a patient who had a contralateral left breast cancer. Low energy images were negative, but very dense breast tissue. On the recombined images, she had what we would call, it's a one view enhancement. So this is an example of enhancing asymmetry in the outer right breast, posterior depth. We did additional spot views, which were negative. We did do a targeted ultrasound that did identify a suspicious sonographic correlate at 9 o'clock. She had an ultrasound guided biopsy, and the clip matched the area of enhancement on CEM. And this was also an invasive lobular cancer. Okay, so I've showed you several cases where CEM is very helpful in the screening setting. In the interest of time, I am just going to show you a table, which I'm happy to share. This table summarizes key findings from studies where CEM was performed in the diagnostic setting. Um, Overall, some key findings. So when evaluating screening recalls, keeping in mind that CEM may not show any associated enhancement with suspicious calcification. So you still want to biopsy calcifications that are suspicious on the low energy images with or without enhancement. When evaluating symptomatic breast, particularly palpables with CEM, CEM has been shown to outperform mammography, but once combined with ultrasound, ultrasound's pretty good at evaluating palpables. So some studies have shown there's really no sensitivity benefit once the palpable is evaluated with ultrasound. And then regarding extent of disease and post-neoadjuvant therapy assessments with CEM, it's just important to understand the limitation with CEM in this setting. CEM has a much more limited field of view than MRI of the chest wall, of the axilla, and of extramammary sites. So keeping that in mind. Also, with the introduction of CEM biopsy, this has made extent of disease CEM exams more feasible because you can actually biopsy additional sites of disease. And then in the post-neoadjuvant therapy setting, one of the benefits of CEM is that the patients can have what we call a one-stop shop exam. They come in for their post-neoadjuvant therapy CEM, and we have the mammogram and we have the recombined images. They don't need to have an MR and then a mammogram. Ultrasound after CEM, what have we learned? We've learned that diagnostic ultrasound after CEM is quite useful. About a third of CEM lesions will have an ultrasound correlate. This is higher for mass lesions, which is consistent with MR literature. Enhancing masses are more likely to have a correlate on ultrasound. And this ultrasound correlate may serve as a biopsy target, which is preferable than a CEM biopsy. We've also found that CEM lesions that have ultrasound correlates are more likely to be malignant. So that is another reason to do the ultrasound. It's a valuable step in the diagnostic workup of indeterminate enhancing lesions. Screening ultrasound, however, is likely not useful after screening CEM. We've shown through a few studies that no cancers have been detected on on ultrasound when combined with CEM. So it doesn't really add a sensitivity benefit and may actually just reduce your specificity by detecting false positives. And this is also similar to the MR literature, where screening ultrasound is really not useful after a screening MRI. CEM guided biopsy. I'm going to start showing you a case. This was a patient who had a history of right breast LCIS and was undergoing screening CEM. Her low energy images show dense breast tissue. Otherwise, they were negative. And on her recombined images, very subtle on the CC view, I'm going to zoom in, there was an enhancing asymmetry. So one view, enhancing asymmetry, that had this like branchy linear distribution. We did additional spot tomo views and ultrasound, which were negative, and then she went to have an MR. We didn't have CEM biopsy at this time. We did identify an enhancing correlate in the upper outer left breast, so she had an MR guided biopsy. And this came back benign breast parenchyma, sclerosing adenosis. This was assessed as concordant, and a 6-month follow-up CEM was recommended. The patient did not return for 6-month follow-up. She returned a year later and had a diagnostic CEM. And what we can see here is now this enhancement, not only does it persist in the outer left breast, but we also see enhancement in the upper left breast. So now it's a two-view finding. And the biopsy marker from the MR biopsy was slightly displaced laterally and superiorly. She had a follow-up MR, again showing persistence of this focal non-mass enhancement in the upper outer quadrant, and the biopsy marker was slightly displaced. Now, this was a year later. During this time, we actually acquired CEM biopsy capability. So instead of repeating the MR biopsy, we performed a CEM biopsy. So this was one of our first CEM biopsies that we performed, which is rather tricky given the subtle finding, but we were able to use that biopsy marker as a landmark. So this is the scout projection from the biopsy. It's a CC view. We approach it horizontally, and we identified this subtle enhancement that was slightly medial to this biopsy marker. This was the pre-fire image, post-fire image, biopsy clip. Biopsy marker is exactly where we wanted it to be in this area of enhancement. And then these arrows are pointing to the displaced biopsy marker from the prior MR biopsy. And this came back DCIS. So this was a CEM biopsy success story for us. This is another CEM biopsy case, a young patient who had a contralateral right mastectomy for breast cancer 1 year ago. She had a tissue expander placed, so she was unable to undergo her screening MR. She had a baseline screening CEM. These are her low energy images, which were negative. On the recombined images, there was a tiny mass at the left upper outer quadrant. Tomo views and ultrasound were negative, so she proceeded to CEM biopsy. This is her scout imaging from the day of biopsy, CC view, the low energy images, and then the paired recombined image. We can see this very subtle tiny mass in the outer breast. This was targeted. These are the stereo pairs. The pre-fire images, clip placement. Again, the post-biopsy mammogram confirms the clip was in good position and matched the area of the enhancing mass. And this was a benign fibroadenoma, so concordant diagnosis. So CEM biopsy was approved in the US for commercial use in 2020. We have two commercially available systems offered through GE and Hologic, and they both enable standard upright or lateral arm stereotactic or tomosynthesis biopsies. So one of the benefits of these systems is that you can, in the same compression on day of biopsy, you can use either 2D tomosynthesis or CEM, recombined enhanced images to target, or a combination of both. So it really behooves you at the day when you're working up a lesion to see if there are any landmarks that can help you so that on the day of biopsy, if it's challenging to identify the area to target, you can use not only the enhanced images, but also the routine, tomo or low energy images. There are two approaches described for a CEM biopsy, the vertical approach and the horizontal. The vertical approach, the needle is perpendicular to the detector. The benefits of the vertical approach is that you have greater sampling in the Z direction, the depth. The drawback that has been described is that if you have a subtle area of enhancement, the lidocaine in the needle may actually obscure the enhancement, and so it may be more difficult to target. The horizontal approach shown here, the benefit, people like it because you can, in the examples I've shown, you can actually see the needle pre-fire and post-fire into the enhancing lesion. But you have to be a little more precise with your depth calculation because you're approaching horizontally. So you really want to be able to see the target in two views so that you're more accurate with your depth calculation. Another step that is advocated for CEM biopsies is to mark the skin before you inject your contrast. And so just making a little outline of the biopsy paddle window. This can be helpful in cases where after you give contrast, let's say you are slightly off center or you want to reposition slightly, you have the techs have a skin mark know their original position when they injected. What have we learned from our initial experience performing CEM biopsies? Very few studies have been published of small um, sample sizes, but showing that biopsies are very quick, under 15 minutes, similar to stereotactic biopsies, and there's a high success rate in these small series. What we have also learned, however, is that CEM biopsy probably should not replace an MR biopsy. There was a study published earlier this year. It was a small study, only 21 patients who had suspicious lesions on MRI. And instead of going to MR biopsy, they went to CEM biopsy. And what they found, granted, small sample size, but less than a third of patients had a CEM correlate. Those that did and had a biopsy, they were all benign. But of those that did not have a CEM correlate, almost a third of them were malignant. So if you have a suspicious lesion on NMR and you attempt a CEM biopsy, if you don't see a correlate or a target, it shouldn't reassure you that it's not real or benign, because in this series, at least a third of them were malignant. Other biopsy challenges that are maybe more unique to CEM described in the literature. Well, similar to MR, the lesion may not enhance on the day of biopsy, or it may enhance and be very subtle, less conspicuous. You may have triangulation issues related to the stereotactic targeting, where you only see the enhancement in one view, and you may want to rely on a landmark, either a biopsy clip, a surgical site, or just something else on the low energy images that can help you target in both views. And then even when you have a very successful targeting and sampling, you do your post-biopsy mammogram, the biopsy marker may be displaced, just like with stereotactic and MR biopsies, or you may have pathology result where you're questioning concordance. I would say just because CEM, we're still gaining experience using CEM biopsies, you may feel less confident in your sampling if the biopsy marker is displaced or the pathology is discordant. And so just keeping in mind that for any of these challenges, you always have the option to rebiopsy, surgically excise, get an MR, or do a 6-month follow-up, depending on your level of suspicion. Okay, clinical implementation. So what have we learned in the last few years? CEM has been increasingly adopted into clinical practice for screening and diagnostic indications. When we use CEM to replace routine mammography, the main advantage is higher sensitivity. But also keep in mind that the acquisition time, availability, radiation dose, and in many cases, patient experience is very similar. The main drawback of using CEM instead of routine mammography is the IV contrast administration. That does have more cost to it. It adds injection time to your exam. You need support staff to place IVs and then also monitor for allergic reactions. When using CEM to replace MR, there are many advantages: faster, less expensive, more widely available. Patients have fewer contraindications to CEM. There's no gadolinium deposition. And as I mentioned, it can be a one-stop shop where you just get one exam, it's your mammo and your enhanced images, rather than two, a mammo and an MR. And then several studies, patient surveys have shown they actually prefer CEM to MR. It's faster, less noisy, more comfortable, and overall they have less anxiety. The drawback of CEM when used instead of MR is that you have a smaller field of view, as we discussed. And then also, despite the promising results from these more recent large studies, there is a question still of whether CEM is as sensitive as MR. And so, in general, for now, we still recommend, if possible, the patient can have an MR and is eligible for MR, MR is preferred. In 2024, we led a focus group through the Society of Breast Imaging where we reported on CEM implementation challenges. This was real feedback from radiologists across the country who had recently, in the past 2 years, started a CEM program. And I include this just to show you that there are resources out there, people are describing their experience and in particular, challenges that they've had with starting a CEM program and some strategies towards mitigating those challenges. And some core themes that have arisen really pertain to patient selection. Who are you offering CEM to? Workflow, everything from IV placement all the way up until, if you're planning a biopsy, how do you coordinate biopsy appointments? Contrast, both injection and reactions, and then billing. And I do want to make one note that in all of these studies, we do report the contrast reaction incidents. And by far, contrast reactions from CEM are very infrequent. And when they do occur, they are mostly mild. And this includes data from a very large meta-analysis of over 14,000 patients. The pooled rate of a contrast reaction from CEM was less than 1%. The severe reaction was less than 0.01%. And this is comparable to contrast CT data. So very safe exam. So I just want to conclude by mentioning the CMIS trial. This is an ongoing multi-center prospective randomized clinical trial being led by my colleague, Dr. Comstock. And the study is designed to compare contrast mammography to tomosynthesis in women who are average risk but have dense breasts and they present for screening. So the trial has been open for a few years now. We anticipate about 2,000 patients total, and enrollment is going to close at the end of 2026. So hopefully we will have preliminary data soon. But the primary objective is to compare overall cancer detection rate, which we expect CEM will outperform tomosynthesis, and then some secondary objectives related to diagnostic performance and tumor biology. In summary, CEM outperforms standard mammography and ultrasound due to its ability to depict both anatomic and vascular changes in the breast. It is a safe and well-tolerated exam with a low frequency of mild contrast reactions, and patients actually prefer CEM. Screening CEM is recommended in women who are at elevated risk but cannot have an MRI, and that may include women who are not eligible for MRI or those that are high risk but can't have an MRI due to a contraindication or access. And there is an ongoing prospective
Зайцев. Ага,
trial
точка.
that aims to validate CEM in the screening setting for women who are average.
Ну, здесь оставь точку, здесь будем писать.
Thank you. I'm happy to answer any questions that you may have.
Thank you a lot, доктор Кристин. Пожалуйста, если есть вопросы, можете их задавать в чат, написать, либо задать на английском, если вы можете, или задавайте на русском, попробуем перевести. Yeah. So you showed some images of false positive enhancement. How do you think? What about, didn't you try to use delayed images? How do you think? Yeah.
Yeah, that's a good question. In my experience, when I was working at Memorial Sloan Kettering, we did have a protocol for delayed CEM images, and that was specifically for patients who were post-neoadjuvant chemotherapy, because we know that sometimes after treatment, due to changes in neovascularity and permeability, the residual tumor. In terms of just diagnostic workups of screening detected lesions, I have not used delayed images. I find that, usually by the time the acquisition's over, it's already been 8 to 10 minutes. So, have you guys been using delayed imaging?
Yeah, in 2021 or 2020, I don't remember exactly. One of our PhD doctors provided her dissertation, and she did delayed images, and she had very good results. Her research showed that on the delayed images, she divided them into wash in, wash out, and aggressive or cancer showed wash out, and
Hmm.
benign lesions they showed washing or persistent.
Yeah, I think that is a great area for further study because the kinetics is what we're kind of missing with the CEM exams.
Mhm.
Also, I don't know if you guys have standardized your order of what views you acquire, but that can also affect enhancement, right? So if like the later acquired views may not show that early enhancement, like you said, the wash-in. And so I think more research is needed for both the standardization of, which views you acquire first
Mm.
versus last, and then also, like you said, delayed imaging, because you can get, yeah, kinetic information, wash in and wash out.
Yeah, yeah. And as I know, before we didn't have special terminology for CM, right? And in the new version of the American College of Radiology for breast imaging, is it described there or no?
For CEM,
Yeah.
yeah, the CEM lexicon, the language is now incorporated into the new BIRADS ACR manual, which was released last month.
Oh, great.
It
Yeah.
was developed in 2022, but it was a supplement. But now it's actually incorporated into
Mm.
the atlas, which is really helpful for um, standardized reporting, and then also for studying, for example, enhancing asymmetry, what the positive predictive value of an enhancing asymmetry is. This will give us more information on um, how to assess a level of suspicion based on like one view findings, for example.
Yeah, absolutely. I guess we have a question. In which clinical scenarios do you consider contrast enhanced mammography superior to breast MRI?
I don't know. I don't know if I can say it's superior. I think it is hopefully non-inferior in many cases. Um, Aside from, I think the greatest use for CEM is just allowing women to have some form of vascular-based imaging. So women that are just never going to have the MR or just don't want it and or don't have access to it. But I don't know if you do have access to an MR, I don't know that we've ever if we need a head-to-head comparison, MR to CEM, um, to show superiority. I don't know if we're there yet. Certainly, I mean, you need the mammogram, right? So even if you're getting MR screening, you still need the mammogram because in all of these trials, they have shown there are cases of low risk DCIS, like calcified DCIS, that is only picked up on the mammogram. So that is a benefit of CEM, but you assume that women getting MR screening are also getting their mammogram screening. But that's something to, they still need the mammogram because we do see DCIS that doesn't enhance, but is only presents on the mammogram, the low energy images.
Another question about tomosynthesis. Can we use it for screening?
With CEM, I think is the probably the question.
I guess they're asking about tomosynthesis alone. Yeah, for breast
So
screening.
yeah, I mean, tomosynthesis is this, at least in the US, we did a study. It's replaced 2D, so it's pretty much standard in many practices for screening, breast cancer screening. Whether you can use it with CEM, so the disadvantage is that it adds radiation. Um, But I do know of at least one or two institutions that are performing CEM and then also acquiring tomosynthesis views as part of their standard protocol. But like I said, many of these studies have shown that you don't even need the tomosynthesis. Once you have the contrast on board, um, tomosynthesis has not picked up a cancer that was missed on the CEM. We will have more data once the CMIS trial is completed, where it's actually comparing CEM to tomosynthesis. But I think CEM just is much more sensitive and you probably don't need the tomosynthesis if you can have a CEM.
Yeah, I absolutely agree with you. Thank you a lot for your presentation.
Thank you for inviting me. This was really fun. I appreciated the invitation and the opportunity. Oh, one more question. Um, After breast surgery, how long should we wait before performing CEM to re obtain reliable results? So that's a good question. I can say anecdotally, so we are at Cornell, we are performing CEM for screening, and we're billing it as a screen. So for our patients, they are not having their CEM until they're due for their annual screen, which is usually 6 months to a year after surgery. Um, any earlier, performing, so you may want to perform the mammogram sooner if you're concerned for residual calcifications, for example. But if it's truly just surveillance after surgery, you kind of want to wait 6 months anyways, at least, just because you can get post-operative enhancement that is just similar to MR. It's more likely to be a false positive. So I would say, unless you're concerned for any residual disease after lumpectomy, probably waiting until they're, your normal protocol that you would wait 6 to 12 months after treatment.
Thank you. More questions, guys? Если есть еще вопросы, пожалуйста. Dr. Kristen, thank you a lot. It was really insightful. I really enjoyed your lecture, and I very like the idea about risk-based screening. Unfortunately, in Kazakhstan, in our country, it doesn't work so well. We use age based screening. Yeah, and I guess we have to maybe change something, yeah, for our patients.
Yeah, it's they kind of go hand in hand. It's been helpful as we've started our CM program. We have done so while we've also started our risk assessment program. So we're able to triage patients. So patients who we assessed to be intermediate risk, we refer them to CEM. Patients that are assessed to be high risk, we refer them to then genetic testing, and most of them are then eligible for MR. I think it is sort of helpful for patients and referrers to know what type of screening their patients are eligible for and which would be preferred. But I also have friends and colleagues who just they offer CEM to everyone and anyone who wants it, which I think is also a fine approach, because there's no harm to it. It's better screening than a mammo. But yeah, risk assessment is very hot right now, in our field. So and I do think it helps with CEM implementation.
Yeah,
Thank you so much.
thank you. We look forward to have you again.
Of course. And feel free to email me if you have any other questions that come up. I know this was cut a little short, but I'm available.
Okay, thank you again. I guess this is the last question, yeah?
Okay. Um, yeah. Granulomatosis, radial scar, and breast cancer cannot be distinguished. Can CEM help make a diagnosis? Um, I I mean, maybe in the future. I don't know of any studies offhand where specifically for granulomatosis or radial scar. I mean, radial scar is always tricky because it can present with the enhancement as well as the distortion. And distortion is one of those findings that has such a high positive predictive value that I feel um, will often get biopsied. I showed the case of the invasive lobular that did not enhance. So I don't know if we are confident yet in passing distortions that don't enhance because invasive lobulars may not enhance. But I would love, I think we all would love for CEM or contrast imaging to help triage these high-risk lesions that often go to surgery and end up being benign.
I think that was the last question. Thank you again.
Okay, you're very welcome. Bye.
Thank you. Have a nice day.